no, Rotterdam now.
Yes, correct.
I'm behind
So
you.
my name is Can Ince. I'm in Rotterdam. I used to be in Amsterdam, but now I'm in Rotterdam. Bigger and better. So thank you very much. It's incredible to see how much interest there is in fluids. I'm really quite impressed so I hope I can meet your expectations. And I'm at the Department of Intensive Care in the research laboratory. I have some declared interests in that I have a company that makes some of the microtools. But my most important thing is I'm a physiologist. I'm not a clinician. So my only role here is to shake the cage a bit, to maybe make you think in a different way about some of the things you do in daily practice. So we will talk about de-escalation, not de-resuscitation, de-escalation. And of course, it's been always very interesting to see that all of the trials that we have that have taken away important, potentially important resuscitation fluids like starches, which I am very regret that that no longer is available, but that's another story, all occur in the rescue and optimization phase, but there's actually very, very little about what happens in the de-escalation phase. So from a physiological point of view, you first give too much fluids and then you have to take it back again. This does not seem logical to me. So this is a great sort of overview from Manu Balbrain about all the problems of fluid overload and accumulation. There are many, which begs the question is, what clinical problem are you trying to solve by giving salty water? It's an interesting question. So now there's too much, and we all know that that leads to fluid overload, and that has got an adverse outcome, also well known and discussed. So once you've given too much, now you've got to take it out again. So what are the tools? Well, basically there's the loop diuretics, the furosemide, you can give albumin, and then ultimately CVVH are the three different categories. In any case, active removal. So we already knew in the beginning that giving furosemide does nothing good to your kidneys. It's very good at achieving extraction of fluids, but does not help renal health. And now we are seeing that there are some darker sides to furosemide. This is an English trial that showed that there was an inpatient diuretic use was linked to a higher incidence of AKI in these severely ill COVID patients. So what does actually furosemide do? Well, it does increase oxidative stress. This is an interesting paper that actually shows that CVVH can induce accumulation of oxygen radicals as indicated by isoprostane excretion in the urine. And we did a very interesting animal study, which is under review. Actually, it's just been accepted for publication. And we were quite amazed how much damage actually furosemide does to the kidney. We saw massive abnormality in the histology, in the tubulars, and the oxygen consumption per sodium reabsorbed, which is like the golden standard, as it were, of renal function, deteriorated with the giving of furosemide. And so we also know that there is a direct hit on the endothelial cells when giving renal replacement therapy. This is one such study. It was a sub-study done by the Albios study, which you well know, which was the albumin study. And what they basically found that Syndican 1 and the VE cadherins, which are the junction proteins between endothelial cells and the glycocalyx, all were independently associated with renal replacement therapy in these trials. So if we then look at some of the adverse event which happens during continuous renal replacement therapy, there is a significant derangement in the electrolyte homeostasis with hypercalcemia, hyperphosphatemia, and of course there's also hypotension. You all get together. So if we now look at one, for example, such thing, which is hypophosphatemia, and of course we need the phosphates for the ATP and for a whole bunch of other reasons, you can see that the longer that the patients are on CERT, in this particular study in any case, the more the hypophosphatemia occurred. So this also has an indirect effect on the 2,3-DPG of the erythrocyte. So you get, because of these electrolyte disturbances, a cascade of other issues occurring, affecting, in this case, the oxygen transport capacity of red blood cells. Whoops. And then there is also, of course, the absorption of antibiotics by CERT. And there is the inflammatory response of the extracorporeal circulation, the interaction of the blood and the plastic tubing, causing a whole bunch of abnormalities, including the upregulation of a number of inflammatory markers. And if we go to hemodialysis, for example, there are another things. I know this is a horror story, but these are happening in more or less conditions. So here's an interesting story about cerebral blood flow being reduced and even myocardial stunning occurring in these patients on CRT. So if we now look at the hemodynamics, it's well, of course, known that withdrawing fluids does lead to hypotension. And here you see a very nice study in hemodialysis in which the cyclic variation, really in intermittent hemodialysis, the changes in blood pressure occurring during such a condition. So CVH-induced hypotension occurs, and this is a study showing that in approximately half of the patients that they measured in a relatively small cohort in our unit, actually, that hypotension occurs, and that you can actually indicate by using near-infrared spectroscopy or pulse pressure variation, which is a index of peripheral perfusion, in being able to identify these effects of venous-venous hemofiltration. So there are complications. They can cause harm. So the question is, well, is there any way of finding out what is really going on? So in Manu's paper, he identifies that the introduction of strategies to maintain and improve tissue perfusion, which is a very interesting concept, about which I hope to say more about in another lecture. What we actually mean by tissue perfusion is, of course, the perfusion of red blood cells in the tissues. So hemodilution actually contraindicates that because it dilutes the tissue perfusion. But that's another story. But more importantly, we really need tools to understand what is going on at the bedside, and we need to introduce physiology at the bedside. So, as you know, many years now I have been promoting the use of imaging the microcirculation at the bedside, and there are various tools which have been introduced. This is the latest one, which we are exhibiting here. And looking at the microcirculation has given us a lot of insight into what is going on at the bedside. So if we now look at PEEP and albumin as two methodologies to alterate the tissue perfusion. So this is a study that Olcay Dilkan did in Burns patients, in which they have the Parkland formula, as you may know, which starts first with aggressive crystalloid resuscitation and then goes over into albumin resuscitation. And what we were able to do was to measure the focal depth of the microcirculation, that's the distance between the surface to the microcirculation, in micrometers as an indicator of tissue edema occurring. And you can see very nicely here that if we look at the focus, that in crystalloids, that focal distance gets stronger, so we get more interstitial edema. There is nothing about crystalloids which corrects intravascular space. It just disappears into the interstitial space, as you can see. And with albumin, indeed, you see that there is a correction of the edema, and it goes back again, a shorter distance, less edema. So very effective. This was an interesting study done in Beijing by my fellow Hai-Wu He, and he looked on dogs on the effect of just not a pathological model, but giving fluids and then putting on PEEP. And he looked at the alveoli here of the exposed lung, and he also measured the distance between one alveoli to the next alveoli, the distance of the septum. which is the interstitial space in the lungs, basically. And what you basically see is that as soon as you put on the PEEP, you get a depression of the cardiac output, which is what you expect. And this can be interpreted as hypovolemia, which is then can be corrected by the giving of fluids. But if you look at the distance here, the septal distance, you see that it reduces with the pre-fluid loading, and that if you increase it, that the septal thickness becomes much more thicker. So when you give PEEP plus fluids, all of the fluids is extravagated to the interstitial space, increasing edema, contraintuitive. We can also look at the de-escalation in CART patients. This is a study done by Emmanuel Faveron in the unit of Shakir Akin in Haga Hospital in The Hague. And you can see that CVVH is very effective in reducing the cumulative fluid balance, and you see a reduction in the capillary density as the fluid gets withdrawn. So a reduction, as it were, in the tissue perfusion. This is the other side of the resuscitation, and that's also a very interesting study here done by Zehra Uz. She was able to maintain the microscope in one and the same place. This is in a cardiac surgery ward, post-ICU, with fluid overload. And if you look carefully, you see a lot of empty spaces here. So there's relatively good convection, but the diffusion is bad. If you now start to apply furosemide here, and we see here very effective in reducing the weight of the patient, the total vessel density starts to increase. As the hematocrit gets higher in the capillaries, you get a recruitment of the microcirculation. And if you see here, this loop here is in exactly the same place here. And you see previously empty vessels now being filled with red blood cells. Everything that is black is red blood cells. So the diffusion distance between the red blood cells and the tissue becomes smaller, so you get a better oxygen extraction. So this is something good that you are achieving by de-escalation. Now, Zehra also did a very interesting trial. This has not been published yet. And this is basically, so the idea of giving too many fluids and then having to withdraw it seems counterintuitive. Maybe better not to give that many fluids. So the question we wanted to address in this trial, perioperative during anesthesia, is what happens to the tissue perfusion when you target liberal and or conservative fluid resuscitation. So there were two groups in this study, a randomized controlled trial that was done in the Department of Anesthesiology in the Academic Medical Center in Amsterdam, and one was done doing so-called fluid responsiveness or goal-directed therapy, targeting stroke volume in the way that is conventional, and comparing that to a low CVP a directed fluid therapy, which involved basically trying to keep CVP as low as possible by giving diuretics in this group. And you saw that indeed it was possible to maintain a lower CVP, about 2 to 3 in this group, compared to about 6 in the goal-directed therapy. And you saw also a lot less fluid accumulation in the low CVP group. Basically, you were peeing out all the fluids that you were being put in. And interestingly, if we now looked at the tissue perfusion, we saw that the low CVP had a much better tissue perfusion than the goal-directed therapy. So keeping the goal to maintain a low fluid intake increases the perfusion of the tissues, which seems to be a very important goal in fluid therapy. Whoops. So Professor Ronco said something very interesting in Vicenza. He says, we need to understand the physiology of the new organs, which I completely and totally agree with. All of these organs, these extracorporeal organ supports are being attached to patients now, and there's a whole physiology associated with them. And there's very, very little research that is being actually done in what the precise effect of taking over the natural physiology by devices is having on homeostasis and the physiology of the patient. So we have started doing this, and This is one, we have a collaboration with Professor Mitzner, who's in this conference too, and they've got this fantastic Fraunhofer Institute in which they make all sorts of extracorporeal organ support devices with material engineers and etc. And here you see a CVVH which they have manufactured for the rat, and we are doing the animal experimentation. Here you see the CVVH. Here you see the actual fluid that we collected out of the CVH in a fluid overloaded rat, and we can look now very, very precisely at the kidney and what effect it has. Here you also see, by the way, a rat cytosorb for cytokine absorption to try and understand what all of these interventions to extracting blood purification interventions are actually really doing at the tissue and cellular level, and we hope to be able to inform you that in the next coming things. So the conclusions that I have, unbelievable. The de-escalation is, of course, a necessary clinical procedure, but be aware that you are paying a price, or rather the patient is paying a price. A liberal fluid resuscitation, to my mind as a physiologist, is completely nonsense, should not be done. De-escalations, while removing the fluids, can themselves cause injuries, as I hope to show. And injury is not only ischemia, hypoxemia, but inflammation and lipid peroxidation, tissue damage, a whole bunch of things. And in my opinion, when giving fluids should always be, this is only as a physiologist that I say, should be accompanied by some form of anti-inflammatory agents, because fluids cause inflammation all over the place, even if it is something like vitamin C. Animal models can help in elucidating the complex mechanisms involved in that, and I want to thank you very much for your attention.